in the audience, but I feel like Ryan and I have probably met some of you from the last trips we've had out to Nairobi. But for those of you who don't know, my name is Britt. I'm an ER doctor in California, and I work at UCLA.
And I'm Ryan Ernst. I am also an emergency medicine doctor. I work at one of the Los Angeles hospitals and also at the University of Utah.
Hi, and there's Mel, if he's still there. Okay. Is he, I think he's
muted.
I think he's purposefully muted.
Yes,
He's muted.
Yes, all right.
And we brought our other friend, Dr. Mel Herbert. He is also a ER doctor in California as well.
All right. So the main reason we wanted to have this meeting streamed off from a discussion we had last week with some providers around the management of COVID cases. From the press briefing today, we know our numbers are going up in terms of COVID cases. Majority of us have not actually seen proper cases, proper meaning cases severe enough needing admission to hospital. And very few, if any, very few have actually seen cases that need to be admitted and intubated. So majority of the cases that we've been seeing and we are still currently dealing with normal asymptomatic or mild symptom patients who are happily being managed in their homes or at the quarantine facility the government has set up. And Britt and Ryan are smack in the middle of the US dealing with real sick patients, getting to admit these patients every day, having to deal with wearing a 95s all day, having to intubate some of these patients. So we thought we'd have a session where we actually talk to clinicians, to emergency care providers who are dealing with severe cases so that when we get there as a country, fingers crossed, we're not going to get there, but in this event that we actually end up having severe disease here in Kenya, then we are we are well prepared to a certain extent on what to do, how to do it. And so the next time a severely ill COVID patient is coming to your hospital, all the staff are not running away, which has happened in a hospital I know, where a patient came in and staff took a different direction. So being prepared means we'll be able to handle these cases more comfortably, not be afraid of handling these cases, and able to pretty much provide the care that some of these patients will need when we get to the point where other countries across the world, Italy, the US, are at the moment. So we're not going to go into the details of the epidemiology, the wear your mask, sneeze into your elbow kind of thing. So we'll go straight into patients coming to the ED. So patients coming to the ED, naturally, where are they going? So in your facilities, Ryan and Britt, where are they going? Is there like a dedicated entry point to COVID cases? Are they coming straight into the ED? Do you have a dedicated reception area? What's happening?
Yeah, well, so I work at 3 different hospitals within California. So even there they're very different hospitals. They're private, they're county. So resources are extremely limited in some and resource rich in others. But as far as kind of triaging and entering the hospital, what we've started to do is basically no one can actually get into the waiting room or into the ER until vital signs are taken, at least a little bit of a history, like do you have a fever, shortness of breath, cough? If you have any respiratory symptoms whatsoever, you get a mask on. We're even doing these for our runs. So like when the ambulance brings a patient to the ER, they can't actually physically get in unless, they're extremely critical patient without getting a set of vital signs, a temperature, and getting a mask on, and then they can enter the hospital.
So this is happening out in the car park or in an ambulance bay of some sort?
Yeah, so a nurse, at one of my hospitals, a nurse will actually physically go out to where the ambulances come, get an initial history of at least what the patient's there for, determine if it's a respiratory symptom, and triage from outside.
Okay, and Ryan, anything different?
Yeah, no, it's a similar system now. Some are a little bit more robust than others. At the University of Utah, the system is very they have not yet seen an influx of patients, so they've had time to really prepare. So they actually have a series of 2 tents, and this is a very resource dependent situation because they have a lot of resources there. So they have an initial tent where people drive through and they just kind of screen. If they have some type of respiratory symptoms, they go to a kind of a COVID protected PPE tent, which is called tent 2, where they're kind of further assessed for COVID risk factors. If they come in and they're having something that they think is completely unrelated to COVID from the initial assessment tent, then they just come into the main ED.
All right, so sounds like a good idea to have triage happening outside before the patients get in. Mel, quickly just check if your mic is working now.
Can you hear me?
Yes, we can hear you. Yes.
Excellent.
All right, good.
I just wanted to add
yes.
one thing to the triaging of these patients as well. And I should also preface, like, this is nothing I ever wanted to be an expert in, but this pandemic has hit us, and it's hit us hard, and it's ramping up every day and getting worse. So we're learning and evolving as we go. Initially, we were really screening people with, we were looking for fever and shortness of breath, cough, some type of respiratory symptom. Now we're finding that a lot of our patients, they may not have a fever. They might have had a fever last week. At first, we were looking for patients that we were considering high risk if they had high risk travel, say to Europe or to China. But now we know that it's so spread out through our community that those high risk features of travel, it doesn't matter anymore. It doesn't apply anymore because it's everywhere. And the majority of people that I'm seeing it, especially at my county facility, have never traveled. And then also the fever, again, some people have it, some people don't. And we're also now finding more and more patients that are presenting with GI symptoms. So vomiting, diarrhea, things that we never would have expected to be a concern for coronavirus. We're seeing kind of atypical presentations of. So as much as you triage for this, at this point, anyone that enters the hospital, to me, you stubbed your toe, you broke your ankle, you're a trauma patient, you have to approach them as if they have coronavirus. I've definitely had trauma patients come in, you do your whole trauma assessment, and then afterwards, you know, they're young, they're healthy, they look fine, and they said, oh, I just came back from Taiwan and I have a cough. Now everyone's been exposed. Yeah. And same with strokes, same with heart attacks. I mean, even though they have a heart attack doesn't mean they also didn't have a fever last week, or they also aren't experiencing a cough. So it's good to have a triaging system, but at this point, with how widespread it is, I'm treating every patient as if they could possibly have coronavirus.
I think, interesting enough, even here where I work at Aga Khan, we've pretty much gotten there. We have patients who are not in contact with anyone. A good chunk don't have fever, but there's some history or other. We've had one present with diarrhea. So we're slowly moving in that direction where patients are coming with symptoms with unrelated travel or contact history. So I think we are probably at the tip where that is actually starting off. So good. PPEs as triage. So what's happening? I mean, do I wear just a mask? So is a nurse or the doctor approaching these patients outside? So we're still at the ambulance bay. I'm going to talk to these patients, try and figure out what's wrong with them. How am I dressed?
It's a good question. I think you see a lot of variety in the standards. And I think there's also in many places it's changing not only because of what we think is the appropriate thing to do, but changing also because of the availability of PPE. So I think there's no set standard, and I think both Britt and Mel can weigh in on this as well. For the initial triage, I think I think it's helpful to think about how the disease is spread first of all, and then adapting your PPE instead of just thinking about, you know, what PPE should be used. So if it's helpful, I think just reviewing that real quick makes sense, if that's okay, Ben. Okay,
go ahead.
Yeah. So, you know, the the disease is thought to be spread mostly through contact and droplets. Contact obviously is, touching fomites on surfaces, on things that, can harbor any little area of moisture that could have the viral particles in it. Droplets are, they're small, particles greater than 5 to 10 microns, which is a millionth of a meter. And those are thought to be spread up to a meter from somebody coughing or breathing or sneezing, and can be spread through the air, that you can then be infected either through your oral mucosa, or then also on the surfaces that you have that might be fomites that might be able to harbor the and then the disease can be spread through, can you hear me still?
Yeah, you disappeared a bit.
All right. And then for procedures that are aerosolizing, such as BiPAP or bag valve mask or intubation, it's thought that the particles can aerosolize, and those can carry much further than 1 meter, and they can stay in the environment for 3 hours or more floating around in the air. So I think for the initial triage, it's appropriate to take droplet and contact precautions. And so the initial people triaging should have at a minimum eye goggles or something to protect the eyes for the mucosa around the eyes, at a minimum a surgical mask, and then probably a gown and gloves if they, if they're not sure. If it's somebody who's like actively coughing and thought to be maybe higher risk, it's probably, if available, putting on an N95 mask is appropriate.
All right. Sometimes from yours, I'm guessing it's a full PPE for the person at the door doing triage. Yeah, you should probably get tested. And just Jeremy is asking, so Bray, are you testing then everyone in your hospital who comes in regardless of symptoms, or what's going on?
Absolutely not. I mean, I wish we could, but the problem is, and again, this varies by the different hospitals that I work at. One hospital that has a lot of resources can test, the test is more widely available. At the other 2 hospitals that I work at, I actually can't order the test until I get approved by our infectious disease doctors. And even last time when I was down in the ER just 2 days ago, we had a box and we had 10 tests left for the hospital. So kind of maybe a little bit about the testing might be helpful as well. So you should I know you all work at different hospitals, different resources, so know your hospital's protocol for testing. One thing that I think it's important to point out is a lot of people at the beginning of this, and are still doing this, which I don't agree with, is if you had a concern for, cough, fever, shortness of breath, they would say test for flu first. Because if they test positive for flu, then you can say, great, it's just the flu, it's not coronavirus. Still go home and quarantine like you would for any viral illness, but it's not coronavirus. And
okay, sorry.
Oh yeah, I was just gonna say, at first we thought that was safe. And that the risk of co-infection, meaning having coronavirus and having another disease like influenza at the same time, was that risk of co-infection was very low, maybe something like 2%. But now with more studies coming out, we're seeing that the risk of co-infection with flu and coronavirus or another virus is actually much higher, sometimes up to 20%. And this risk of co-infection is much higher in our older people, with more comorbidities that are at a higher risk of, severe illness from coronavirus. So doing the approach to testing of test for flu, if positive, stop there because it's not coronavirus, really is pretty dangerous, I think, because they could have flu and coronavirus and need to be treated like they have coronavirus.
Yeah,
Sorry,
so
yeah.
the good thing is, yeah, sorry, you know, yeah, the good thing is in our setting, we don't even test for flu. So
Okay, all
patients
right.
presenting with difficulty in breathing in our setup is a pneumonia, is tuberculosis, it's heart failure, and in certain centers, you actually can't think about pulmonary embolism, but majority of people, your best test would be an X-ray. So for us, I guess our differentials really are the common one is bacterial pneumonia or community-acquired pneumonia,
Sure.
your heart failure patients, especially in the elderly population. Once in a while, you bump into a PE, that's also getting quite common. So uh, just regular influenza is not really one of the things we'll see or
Okay.
really, but then we have all the HIV complications in terms of PCP or PJP and many other diseases. So
Yeah, so I'm seeing the questions on the side. So a little
yes,
bit also with the testing. So um, initially, if somebody comes in and we're worried about it, and we can talk about treatment options and all of that debate too, but there's nothing much you can do, right? So unless they are hypoxic, unless they are requiring oxygen or IV fluids for dehydration, there isn't much more we can do. So if they can go home, whether I test them or not doesn't really change my management. So if I think they can go home and I think they have coronavirus, then at this point in my head, they probably have coronavirus, and I give them very strict instructions on how to quarantine properly and how to stay at home and minimize any contact with anyone. The
okay.
times where we do the testing is helpful, is once we're bringing them into the hospital. Oh, at this point, almost everyone that we're bringing into the hospital and we're really worried about, we can test for, because when they come to the hospital, we have to have proper isolation from them, from the other patients, and knowing what PPE we need to basically interact with that patient. Uh, the problem is with the test, and I don't know what the testing, how it works in Kenya, but it's taking about up to 10 days for a lot of our hospitals to even get the test results back. So how good is the test if you can't even get a result for 10 days? And we can also
Okay,
talk about how good the test is regardless.
yeah.
But at this point, it's not really so much that it's changing management. It just is helping to direct our isolation in the hospital.
Okay, so I guess because for us, we're starting to kind of do some of that where, yeah, you have a flu, it could be COVID, but you are healthy, go home, self-isolate for 2 weeks. And I think that's potentially something to look at. And I want us to focus more on the severe cases coming into the hospital. Those going home, to be honest, I'm also with you that whether it's positive or negative, just go self-isolate for 14 days. If you're not really coming into the hospital, then we are happy with you going out there and not necessarily testing you. I'm seeing some questions on community and masks. We'll potentially move away from that one, the epidemiological questions, and also mass testing. So, because I want us to focus on that patient who has to come into the hospital, that patient who has to be admitted. So what are you seeing? So which of these patients, or how are they presenting? The ones where going home is not really an option. So what kind of presentations are they coming with? So you see them at triage, they look sick enough to come into the unit. So how sick are they? What are you seeing? Maybe describe, are they hypotensive? Are they tachycardic? Are they hypoxic? What are you seeing? Maybe Ryan can start off. Yes.
Yeah, so I think it's a kind of a wide variety of presentations. If we were to group them, a lot of times what we're seeing, hypoxia is kind of the criteria that we're starting to look at as that really helps us gauge how sick they are, more so than the remainder of their vital signs, including temperature. One thing that's interesting about these patients is they seem to be presenting with levels of oxygen that are very low, and yet they don't seem to be in acute respiratory distress. And so the last patient that I admitted, who is actually the family member who worked in our hospital, his oxygen saturation, he's a healthy 51-year-old gentleman, his oxygen saturations were in the 70s, mid 70s, but he was talking and answering questions. And you know, his respiratory rate was a little bit fast, but I certainly wouldn't describe him as being in respiratory distress. When we got his x-ray, he had, you know, bilateral infiltrates throughout. It was a very ugly looking chest x-ray, but definitely kind of outer proportion to how he looked. And so I think that those patients are maybe like the the stereotypical patient, but I think they are ranging, kind of like Britt was saying. We're seeing a lot of patients that are presenting with abdominal pain or diarrhea that end up having florid coronavirus infection. And then there's also the patients on the extreme end that are coming in and, you know, acute respiratory failure or even arrest. And so there's a wide range, but I think mostly fever, cough, and hypoxia is kind of the typical, with like a you know, looking maybe clinically okay, but their oxygen saturation profoundly low.
Okay, maybe quickly, maybe pick on that, and maybe Britt can also explain us and answer this one. So should we be checking saturations as a triage tool? Because that has come up in terms of some discussions. Is should we, as you said, if it's this healthy looking person, slight tachypnea, which may not necessarily, I mean, if you look at your triage notes, respiratory rate is always 16. But so should we be checking SATs even for the patient who looks perfectly well, should be going home, whether they test or not test? But at that desk where, for example, they're coming in, should we be checking SATs and using that to determine how sick someone is versus just the usual eyeball that we give? I don't know what Britt, maybe give us some.
I do think that checking the oxygen saturation is important, because like Ryan said, especially early on in the disease, and we can send them home, you know, fever, cough, shortness of breath, and you're like, okay, you look fine. There's actually, I mean, I'm seeing more and more younger people presenting with pretty severe disease, and they can compensate for a while. They can actually maybe look okay, but are profoundly hypoxic. Most of the patients coming in are, like Ryan said, satting in the 70s, satting in the 80s, and still talking to you fairly normally. And then you get chest x-rays on these people, and sometimes their chest x-rays and the way they look are very different. They look okay and their chest x-ray looks absolutely terrible. I don't know if we could share the screen, because we have I have a chest x-ray from one of my patients from just 2 days ago, which is pretty classic for what at least I've been continuously seeing on shift. But I do think that the checking an oxygen saturation is important, because we also are finding that taking the shortness of breath seriously is important, because a lot of the people that develop severe illness from this are the ones that are presenting with hypoxia.
Okay, so someone quickly taking us back to triage. So maybe quick answer on this one. How often is your triage team changing PPEs? Is it per patient, or is it just one person dedicated to triage and just spending the whole day there with their PPEs?
I think in an ideal world, you would change, like I think the design for these disposable items is that they change PPE for each patient, but the reality is there's so many patients and there's so few PPE that people are just donning for their entire shift.
Okay. All right. So far we've triaged these patients. So they're looking a bit sick. Hypoxia is one of the things on the criteria. And so you mentioned diarrhea. Diarrhea is very familiar for us based on very many factors. It's actually one of the top 10 causes of death in this country. When you say diarrhea, is it a little diarrhea? Is it profuse diarrhea? Are we talking cholera or just a bad stomach diarrhea? What's the presentation?
Britt, you can maybe comment on this as well, but the patients that I've seen that have later turned out to be coronavirus positive, it's just very vague symptoms. There's nothing, it's not like, oh, they've had florid, 20 stools a day. They're just like, oh, I've had some loose stools and abdominal cramping, and I feel, abdominal pain or bloating. It's maybe some nausea and maybe some vomiting. It's completely non-specific and not, unfortunately, it's not helpful in any way to categorize it as, a typical coronavirus, COVID.
Okay.
Yeah,
Cool.
I totally would agree. I think it's more vague, and if they're having profound diarrhea, I think right now in our brains of coronavirus, we're putting everything on coronavirus, but like you're saying, it's really important to remember the whole rest of your differential diagnosis, because shortness of breath and a fever can be coronavirus. It could also be a PE. So you don't want to like corner yourself into the COVID like that's what everybody has. It's just something to consider with kind of vague GI symptoms.
Okay, good. Yeah, I agree on that one, especially seeing other patients coming through the ED and everyone is just focused on COVID, forgetting. Like, we had one patient who presented some pain, some epigastric pain, some nose stool, ended up being pancreatitis, and but the doc was COVID. But yeah, so
Yeah.
other patients are still showing up in the ED. All right, so so in the ED, so we have these patients. You're doing a triage. You quickly picked up what's wrong with them. Are they? I mean, I'm guessing you have full PPE when you're managing this patient. So apart from oxygen, and we'll go down the whole hypoxia to intubation route, because I see some questions coming on this. But so apart from hypoxia, are they septic in terms of, are they hypotensive? Do they need fluid resuscitation? How are they looking?
The very sick patients may be hypotensive, and at the hospitals I work at, I haven't seen a ton of that yet. But the challenge is for the hypotensive patients, we're finding, if you are aggressive with your fluid resuscitation, this is then worsening their outcomes because their ARDS and their pulmonary edema worsens. And so more of a fluid restrictive strategy is being employed. And if they're hypotensive, using pressors early and not defaulting to, like sepsis guidelines where you would get 30 cc's per kilogram.
All right, when you say restrictive, just before break comes in, when you say restrictive, what do you mean? Restrictive fluid, how much are we talking about?
I don't know if
500 mLs.
Go Ryan, go.
Oh no, I thought you wanted Brit. So yeah, no, for these patients, I would probably, depending on, if they're young and healthy, I might start with just a liter, or if they're older, I might go less. But now, I'm definitely changing my management just in the last week, in that so many people presenting with symptoms are likely to have co-infection with coronavirus now that it's kind of just so widespread that even somebody who previously maybe looked like they were, bacteremic or septic, we would now assume that they have coronavirus, and then you have to be careful. So some of these patients, I'm giving no fluids at all, because after they're getting admitted, some of them in some places are getting Lasix. And so if I had a patient that was hypotensive and I had a high suspicion that coronavirus was the cause of that, I would probably go straight to pressors and only give them fluids if I thought there was, acute evidence that they were, hypovolemic.
All right, great.
Yeah, I think, sorry, I cut out there for 1 second, but I think this isn't the person you flood with fluids. This isn't like just your bacteremic septic person. I haven't seen a ton of hypotension at this point. Really, it's more the hypoxia, tachycardia, and pretty high fevers. So I think giving them oxygen and treating their fever first and foremost. Some of them are going to be dehydrated for sure. So maybe giving like aliquots of 500 cc's at a time and seeing how they're doing. But that could definitely, too much fluid will definitely worsen their respiratory status. And I think we have to remember that the majority of these people that we're seeing are 60s, 70s. They could have comorbidities. We also know that this virus is causing a lot of cardiac issues. And we're seeing elevated troponins. We're seeing inflammation in the cardiac muscle. So swamping them with fluids is not in the patient's best interest whatsoever. I think it's more treating the fever, treating the hypoxia, and reassessing.
All right, good. All right, so at least don't give too much fluids. In fact, don't give fluids at all if you can avoid it. Inotropes, and from previous discussions and on our online platforms, you can start your inotropes peripherally. There's a lot of papers on this, so you don't have to have a central line start your inotropic support just on that point. So, because I want to go back now to the real problem, which is the whole airway problem, oxygen problem. So quick question. Someone was asking, how are we decontaminating the SpO2 probe? If you're going to test people periodically about with their SATs, are we decontaminating it, or just every patient puts their finger in there and sanitizes after?
Yeah, I think what we would do is we have like just the canisters of wipes, and they have different chemical makeups. I'd have to look those up, but some type of chemical decontamination afterwards, just wiping that down, because that's an area of contact that you could easily and very highly likely be spreading the disease. So you definitely have to decontaminate after each use. You have to wipe that down.
Decontaminate the probe. Preferentially also ask your patient to sanitize their hands before putting the probe on. That would also be a way to reduce transmission. But yes, it's a good question. It's a potential. I mean, you can imagine every patient does go through the same SARS probe. All right, so majority of patients, are we starting with the nasal prongs and then going to, are we using simple face masks, or are we going to non-rebreather masks? Where are we?
Yeah, this is a big, hot debate right now, and I think probably Mel has a lot to add to this. I think, you start stepwise, of course. You can start with your nasal cannula, move up to the non-rebreather. The problem is, which we can talk about this all day, is then if you start getting into even high flow nasal cannula, if that's available at your hospital, or CPAP, BiPAP, any nebulized treatment. So if you want to give them albuterol, ipratropium, anything like that, that's going to be nebulized. The problem is now you're going from respiratory droplets to aerosolized particles of this virus. So all of that really should be done in a negative pressure room. And the person in there, right, so that's not available. So the person in there has to be now we're not talking about a surgical mask. Now you've aerosolized these particles, and you need to be in the N95. Always with the goggles, always with the gloves, but now you need to move to the N95 because those droplets have now become tiny particles that you can breathe in and are basically shed throughout the entire room. So that definitely gets into a grayer zone of, if you can't just, if the hypoxia doesn't resolve with just the nasal cannula or even a non-rebreather, and you have to do something more advanced, what's within the best interest of protecting you, protecting the patient? Do you go to intubation? Do you try these nebulized treatments? There's a lot up for debate there.
Right. Ryan, what do you think?
Yeah, I think the nasal cannula obviously is our first go-to. We are getting more comfortable using the high flow nasal cannula, and the thought that if it's not too high, we are at low risk of aerosolization. And so we're starting to use that. It's easier if you have a negative pressure room because that makes everybody a little bit less nervous, but I think that's really limited. Even in the very busy hospital I work at outside of Los Angeles, there's only a single negative pressure room. So most of the patients that we're treating are not in that room. And then, moving up to, CPAP, if you can be in a closed circuit where people can be protected from aerosolized particles, and CPAP versus BiPAP. BiPAP is probably worsening conditions, and then intubation. And
all right, So good. So I'm saying, the question, if you don't have negative isolation room, so far from what I'm seeing around is a room with a closed door, and essentially when you're getting into the room, have full PPEs, including your N95 masks. Yes, so the closed rooms with closed doors prevent things getting out of the door, I think I don't know, does that sound right from your end?
Yeah, pretty much. Again, the hospitals that I work at, there's maybe, I mean, it differs from each hospital, but there's, 4 negative pressure rooms at one of them, and they, at any given time, they're taken up. And the problem also with the negative pressure room, or any room that a coronavirus patient is in, it takes a significant time to turn that room around to put a new patient in there, because of the cleaning process is much longer than just your normal exam room. So we are definitely running into that issue now. I know that, especially in New York, they're lined up two rows in the hallway on oxygen, just because they're out of space.
Okay, so preferentially negative pressure, assuming you have one, which many people don't have. Then if that's not possible, then a room with a closed door. Then if that's not possible, then a corner somewhere in your unit kind of situation.
Yeah.
Yes.
Yeah.
If you have a HEPA filter, Sylvia, yeah. Because I'm saying if you have a HEPA filter, you're lucky, but I don't think that's something we have.
We are using those. We are using those in our closed doors to try and make them negative pressure.
Okay. All right. Good. All right. So patient comes in, we've triaged them, they're hypoxic, we've set them on some nasal cannula, and we move up into CPAP. So there was a debate earlier about using CPAP for now, but it's nice that you are saying we can use CPAP.
I think Mel has some words. That's the Brittany guest Mel, I think.
Yes. Let me unmute him. Where is Mel? Unmute. Let's just see. There are like 5 faces of him here. Mel, can
you got me?
Yes, there we go. Maybe you can comment on this.
Yeah, I got a lot of comments because, first of all, let's talk about the hypoxia. The hypoxia in this disease is unlike anything that people have seen before. It's profound. There's not a hypoxic response the way there normally is initially. So people have SATs in the 60s that just don't look very bad initially. And that is much more like high altitude illness than it is a normal pneumonia or even a viral pneumonia. So the idea of triaging people with a pulse ox, I think, is really important. And in fact, the way I would do that is I would have a table out there and do a no-touch technique, have the patient put on the pulse ox, be 6 feet from the nurse, tell them, get them to tell you what the number is, and decide home or admission, and then have them wipe it off. CPAP, BiPAP, we've really changed even in the last week. It was the safest thing for the staff is to early intubate, viral filters, closed circuit. But it turns out that probably the best thing for the patient is to avoid intubation for as long as possible, to use high flow nasal O2, to use BiPAP, and to not intubate. So there's this tension here right now about what's best for the patient and what's best for the crew. The problem also with that is if you wait too long, everybody's experience in New York and now occurring here is that when patients crash, they do it really fast. And it takes a while to put on all your protective equipment. So again, there's that tension of you want to wait as long as you can, but if you wait too long and they crash, then it really becomes a very dangerous situation. In terms of where to put the patients, you're talking right now sort of like a high resource hospital, but I think you're going to be overwhelmed pretty quickly. If it turns out to be like New York, if it turns out to be like Italy, then I think you actually have to take the patients out of the hospital. You have to put them in tents outside. If we look at the experience from 1918, the patients that actually did the best were the ones that were in the tents outside the hospital. There was lots of fresh air. There was lots of UV light. This is a terrible virus, but it's pretty weak. It's got a lipid bilayer, and just soap and UV radiation kills it. So what they found in 1918 is that the patients that were in the hospital were probably rebreathing virus. Their mortality was like twice that of the people that were outside in the tents. So if you get to the point where you're overwhelmed, I think you need to start moving patients outside, in tents, lots of free-flowing wind, air, UV light, and oxygen. I think you really need to think about the people you'll be able to help is not the ones you can intubate, because you'll run out of stuff pretty quickly. It's getting as much oxygen as you can for those people that are bad but not critical. They're the ones I think you'll have the best chance of saving.
Okay, good. That's quite interesting. Yeah, because we're working on setting up a tent at the moment. But yeah, figuring out how to get oxygen there would be a whole new discussion. All right. Just someone asking pulse ox, which is very interesting. Pulse oximeters are not readily available across many facilities here in the country. Yeah. Plan B? Would you think of a plan B? I saw there was this thing that was going around, and I think WHO came and said that's not really true. The thing of holding your breath, does that work? Because I saw it and I was like, yeah, that ends on right. But yes, what do you guys think?
I was talking about this, hold your breath for 10 seconds, and if you don't cough, you don't have it. I don't think that's a great exam.
Yeah, and like Mel said, this is challenging because you can't go by, surprisingly, a lot of these folks, they're not tachypnic, they're not tachycardic, but their oxygen sats are incredibly low and their chest x-ray is ugly. So it's kind of hard because you can't rely on what we're used to relying on is just, clinical gestalt by looking at them. Obviously, if they are tachycardic, then that would suggest obviously that they're sick and you need to pay attention to it. But I don't think just the typical clinical assessment is fully reliable, unfortunately.
And just discussing that, and I think maybe that's one thing we potentially can look at and should consider on our setting. We probably have more availability of chest x-rays in some areas versus a pulse ox sometimes, which is tricky. Maybe for that patient you really suspect and then getting an X-ray on them, maybe just an option and trying to check if what you see from there. I don't know. So,
but even
the imaging, yeah. Sorry.
Even the folks with ugly X-rays, sometimes they're doing okay. Is the other problem? So it's like Mel, you might be able to speak on this, but yeah, unfortunately, that also maybe not the best, triage tool because they actually might be satting fine and holding up with a ugly looking chest X-ray.
All right. Mel, you're up.
Yeah. The problem with this is that there's this discordant things going on, which makes it really different than anything we've dealt with before. The patient's clinical state doesn't look like their pulse ox. Their chest X-ray can be terrible and they're not too bad. CT scan is more sensitive, but nobody has the resources to scan everybody. Ultrasound is also useful, but there are some specific findings. So if you don't have X-ray, you could do that. But I think you've all got to stop and ask yourself, how is this going to change management? Because you can look at all of these things and they're interesting, but you really have to ask the question, what's the one thing that changes management? And I think it's pulse ox is really looking at the patient, how sick they are, looking at their pulse ox. It doesn't matter what the X-ray looks like. We've got thousands of X-rays now that just are terrible and they don't really correlate very well. So I think, again, when you're resource strapped, you just have to look at the patient, do a pulse ox, put them on oxygen. If you don't have a pulse ox, I don't know what, you just have to go purely clinical. How sick do they look? How cyanotic are they? This concept of holding your breath for 10 minutes actually came from a physical education instructor, and it blew up on social media, and it is absolutely crap. Don't believe it.
Hi, thanks, Mel. All right, so let's go down. So this patient pretty much now is at the point where they're desaturating. Your 100% oxygen is not really getting them anywhere. Delay intubation. So let's assume this patient, for example, I put them on 100% oxygen, high flow nasal oxygen is really available. I put them on a non-rebreather mask. CPAP, BiPAP may not be available in some settings. At what points do I say I need to intubate this guy? So I'm assuming this is the guy who is not in respiratory failure. So they're still breathing, but I'm cranking up their oxygen as much as possible. The best I'm getting is an 88% oxygen saturation. We moved from 60 or something. Is there a point where I'm like, okay, I need to tube this patient, or am I happy to accept the 88%? I'm getting, even with, let's say, even the BiPAP and the CPAP, is there an oxygen saturation point I should be like, okay, yes, you're not looking sick, I should put a tube? I don't know. What do you think?
I think that you have to look at the patient because, you know, if they are looking okay and you think maybe if you just get them on that with that non-rebreather for long enough and you're okay with like mid-high-ish 80s, that's one thing. But the patient that I intubated a couple days ago, he was transferred to me actually, and he had been on a non-rebreather and kept getting, you know, went from 10 liters to 15 liters on the non-rebreather, and you're just looking at him and he's diaphoretic, he's exhausted. You know, he was a tough guy, but when I asked him like, are you tired? He was like, yes. And so at that point, you know, it's hard. It's easier when they're in respiratory distress and you just know, I just need to intubate this person. And like we said, they can be really hypoxic and still look okay. But I think it's constantly assessing the patient and really just looking, are you getting tired? If you're tiring out, like this is going nowhere. And so it was at that point where he really was like, no, I'm exhausted. And he was clearly starting to really, really struggle to breathe, that I decided to intubate him. Also, doing an intubation with somebody who's sitting in the 70s and paralyzing that person is not ideal. So you don't want to get them to the point where they're so hypoxic, you've been waiting too long, and now you paralyze them and they become apneic and code on you. So it is a gray area, but I think a lot of it has to do with looking at the patient and seeing how they're clinically progressing.
Okay, good.
And I would also, Ben, I would just add to that too, because I think that's 100% right. And then also we have to take into account what, you know, because pretty soon you have to take into account the systems that you have available to you and the system burden. And so if you have a patient who's sitting at 88% on, you know, their nasal cannula and you're concerned about them or they're non-rebreather, but you can keep them in an area where they are monitored, you know, and someone can like see them or check in on them every 10 minutes, that's one thing. If that patient is going to a room and someone's going to look at them every 3 hours, that's a whole different situation. And so that same patient, if they can't be monitored closely because they can crump quickly, you would probably lean more towards, you know, getting a definitive airway on that person rather than having them unmonitored, even at a relatively low saturation. But then also, I think, you know, the big problem that we're seeing in Italy and starting to see in the US as well is just that the ICUs are filling up and we have, you know, limitations of ventilators. And so the default to intubating these people has to be taken into consideration your overall availability. If you have 3 vents in your entire hospital, you need to start early choosing who is appropriately getting intubated, because that people are staying on vents for long periods of time. And so you may be intubating people that have less likelihood of survival when someone later on might be more appropriately using that vent. So I think taking into your capacity, your overall capacity for ICU beds and ventilators and management of that is unfortunately, I think needs to be done on the front end.
All right, quick question on blood gas. Is that helpful?
Yeah, I was just talking to Dr. Krager about this last night, because I think there's some consideration that with these patients with really profound hypoxia, that maybe there's a mismatch, and maybe this is just something like a, hemoglobinopathy, where the pulse oximetry is not matching with the actual PaO2 on the ABG. From what she's seen, from what I've seen, and from what I've read so far, they do match. So I don't know if the ABG buys you anything additional if you have pulse ox. If you're at a place that has no pulse ox, but you can get an ABG, then perhaps that would be helpful. But that seems like probably if you're somewhere you can get ABGs, then you probably also have a pulse ox. But I don't know, Mel or Britt, have you guys heard anything different from a disparity between ABG and the peripheral pulse ox?
No, this came up last night with our live show. That was the concern that maybe there's a hemoglobinopathy like methemoglobinemia can produce these falsely low pulse ox compared to ABG. But I think people have been so busy when these patients are coming in, they are not getting them at the same time. So Sarah's experience is probably as good as anybody's right now.
Quick one, Ryan, do you have the x-rays? Someone wants to have a look at these x-rays before we go into
Yeah,
the
let me
information. Yes.
get back to, let's see if I can, there's a good way to share this.
I felt like I kept looking at the same person's x-ray all shift because they're starting to look very uniform.
Whoa.
Yeah, so this was like one of the 20 patients that I saw, and they start to all look very similar. I think this guy was sitting at probably low 80s when he came in. And so as you can see, like not like a normal pneumonia picture, you don't see a focal consolidation. They could describe it as kind of this like ground glass diffuse opacifications. And you see it bilaterally, it's throughout. And the CT scans, if you get them on these patients, which again, and I don't think is necessary or changes any of your management, unless you're looking for something like a PE or another diagnosis. The CT scan findings are profound. It's just these multifocal ground glass opacities everywhere.
And so just looking at that, because I want to just show, I mean, in our setting, we've seen these x-rays before. Yes, with some ARDS, but also with, what's this thing called? The PJP, especially in your HIV positive patients. So I'm just going to share a similar x-ray. As you can see, pretty much this is an x-ray of a patient with PCP, similar presentation. So in our setting, yes, COVID is one option, but in our setting, testing the patient for HIV may not be such a bad idea, especially because COVID, we may not be able to do much for that, but PCP has treatment, and so we should not be missing out our PCP patients saying, oh, you got COVID. TB rarely will present like this unless you have miliary TB. And I will try and get an image of miliary TB as we discuss. But so yes, there is COVID, and yes, the x-rays may look like this, but also think of your differential diagnosis. On my list is miliary TB and PCP being quite common in our setting.
Yeah, I mean, I think that's a great point, Ben, because I mean, even when we're admitting these patients to the hospital, I can't say, I mean, again, that COVID test might take a week to 10 days to come back. They're febrile, they're tachycardic, their x-ray looks like crud. And I mean, I'm still giving them IV antibiotics because I can't say it isn't something bacterial potentially still. And that's something I've had a lot of conversations with our infectious disease people about. Greg Moran, all of you, is like my ID guru, and he still, you know, until we know, you can't just corner yourself into this is coronavirus, because you're right, there are things where if you give antibiotics, you can reverse this, you can treat this, and so you shouldn't withhold antibiotics just because you think it might be coronavirus.
Ryan, you had a point?
Yeah, there's, and it was mostly because we were talking about imaging, and there was an earlier question of, you know, using CT scan. And I think, yes, CT scan is slightly more sensitive if your coronavirus test is indeterminate, but I don't think we should be, we're recommending against using CT scan as a screening test. Obviously it's, you know, not readily available. And I think if you have a suspicion, even if if you get a coronavirus test that's negative, instead of relying on imaging to tell you one way or the other, just your clinical suspicion and the clinical presentation. If you are thinking that it's coronavirus, just treat it as if it's coronavirus.
Right.
And then, shoot, I had a second point that I have forgotten. I'll come back to it. I'm sure it'll cycle back into my brain.
Yeah, so this is actually miliary TB. Sorry, go on, Ryan.
Oh, yeah. The second question was, the other thing too to keep in mind with or without coronavirus, there's a high rate of cardiomyopathies and heart failure stemming from coronavirus, or that may just be underlying. And so the other thing that can give you diffuse pulmonary infiltrates is heart failure. And one good way to determine that is if you have access to bedside ultrasound, just taking a look at their cardiac function, because you may, this may seem like a primary pulmonary issue, but if you take a look and they have a severely decreased ejection fraction, left ventricular function, that might clue you into why they're having, shortness of breath and hypoxia and diffuse infiltrates as well.
Yeah, well,
To
that
totally
may not
complicate
be
it, it could be both.
Yeah, yes, exactly. So bedside ultrasound echoes are very limited for sure. But yeah, so this is an extra patient with miliary TB. So again, you can see the similarities. I'm sure that if an radiologist would be able to pick up the minute things, differences in the x-ray, but pretty much almost around the same. I will try and get one also for the heart failure patient. So you still have to think of your differentials. In terms of, I see a question on what PP is. So the x-rays are of course done, on the question of whether x-rays are done before COVID test, pretty much probably, because COVID test is just a swab. So we'll get the x-ray from the word go. And most patients, the COVID test will take, in our setting, even 24 hours to come out. So you may swab before or after the x-ray, but all precautions should be taken when you suspect COVID is on your list. Yes. Yes, so maybe we'll go down the question. So if you have any questions, by the way, we're already 1 hour into this. We have 1 hour to go. If you have any questions, just type them out on the chat side. We will answer them as we go along. I want us to go into now the point where we are deciding to intubate this patient. What process are we doing? How are we dressed? Yes, what are we worried about when you're intubating? How fast should we intubate? Should we bug the patients? Those are questions that are coming up and being discussed periodically. So who wants to go first?
I can start, and Brian, you fill in all the things I missed, okay?
Sounds good.
I get the easy part. No, so yeah, so when you do decide to intubate these people, if you pre-oxygenating them as best you can, obviously, like I said, you want to get that oxygen up. Paralyzing a person that's satting at 70% is not ideal. And then we are very aggressive about limiting the number of people in the room. I think first and foremost, to keep people safe. I've done it to the point where I think there's been a total of 3 people in the room, me, the RT, and a nurse to push the meds. Those 3 people going into the room need to be in full N95, goggles, mask, gloves, and a gown. We had talked about a PAPR before, but I don't think that's available at any of your facilities, so we don't really need to go into the details of that. But everyone needs to be in an N95. One thing that I've noticed is actually really important before you even go into the room is ask someone to look at you and make sure you have everything on that you need. Because I've spent so much time in goggles, sometimes I honestly can't tell if they're on my face or not anymore. And I know it sounds silly, but just like take that checkpoint, because no matter how bad the patient's crashing and it's all our gut feeling to run into the room and start resuscitating and doing all those things, you need to protect you and your team first. So safety first is always get your N95, make sure you have everything on that you need. Pre-oxygenate as best you can. As far as the bagging goes, do you have viral filters, Ben?
Yep.
Okay.
In some places,
so
yes, they're available.
Okay. Make sure that you have a viral filter available. Try and bag as, if you can, bag as little as possible or even not at all, and just prioritize getting the tube in as quickly as possible. If there's multiple people at your institution that can intubate or do intubate, this is a super high risk time. This can be a really complicated intubation, so it should be the person with the most experience. It's not the time to have a student do it or a learner. Like, the most experienced person should be the one in there intubating.
All right, maybe I want to take a step back a bit before we get to the tube part. So you said we've got 3, so we have a room. So ideally you're doing it in a closed room, whether there's negative pressure or not. that's neither here nor there. So you're in a room somewhere where possible. Full PPE is head to toe, glass gowns, masks, N95 masks. 3 people. So you have 3 people in there doing the intubation. You mentioned 3 people. Can we do it with 2? I'm trying to say
Yes.
is our
I
limited.
mean, you could push your meds and then go up to the head of the bed. It's
one
totally
do the
possible.
drugs, one do the intubation.
Yeah.
Right.
That's,
I mean, and
that's,
we go ahead.
Yeah,
so
right.
just that's what we're doing in Antelope Valley right now, is just 2 people, the RT and the doc. The doc pushes the meds and then intubates, and the RT assists.
Okay, good. Because I think trying to limit staffing. I know. I mean, many people don't want to be in that room at that point. So ideally, do it in a closed room, plus minus all the other stuff that goes in the room. Full PPE is for everyone. Now, bagging. You've said if you sorry.
Just one thing to add to that, though, Ben. I think
Yeah.
if when you are running at a minimum like that and you just have 2 people in the room, I would definitely recommend having somebody who is already geared up with N95 and full PPE, so that if things go south, that you can step into the room as needed without then having to scramble and find all your PPE. Because as you know, if things aren't going well, they won't go well in a hurry. And with only 2 people in the room, especially once you've intubated, it's hard to get around the patient, the bed. There's not a whole lot of room. I have at least 1/3 person prepared to come in and help out.
That sounds like a good plan. So they're standing outside as backup in case we need someone else to come in. So that's a very good idea. So bugging. Yes, so limit bugging as much as possible. Do a slick intubation. There was I can't remember the name we're using it, where you're putting nasal prongs while intubating. Are we doing that?
Yeah, I mean, any pre-oxygenation that you can get. And I always, it's just my practice to keep the nasal cannula on for any intubation. As far as the intubation goes, do you have glide scopes? No. Okay, never mind. Yeah, okay. I didn't know if that was accessible at some hospitals. So I definitely agree with Brian to limit the number of people in there, but have backup. I've had make sure the crash cart's out there, make sure all of your extra medications that you could even imagine needing, just have it all right there. If you have a way, if there's like a speaker in the room or a telephone that you can have on, and just put it on speakerphone and have the other person outside put their phone on speakerphone so you can try and communicate. Because you're going to be mouthing something with an N95 on, which is not going to help anyone. So if you can have any kind of phone or device on to talk to the person outside, that's also super helpful. The bagging issue is because once you start bagging, again, you're aerosolizing those droplet particles. So you want to try and limit, especially if you're not in a negative pressure room, how much of that aerosolization you're doing. And if you don't need to bag in between, it's paralyze and get the tube in. Just first pass as fast as you can. And then if you do need to bag while the RT is putting up the vent, you have that viral filter. So everyone has a little bit of a different setup, but it usually goes on the end of the ET tube into the BVM to bag, so you can bag safely without aerosolizing those particles.
All right, good. The oxygen, someone is asking, nasal cannula, normally I crank it up to its maximum or whatever that will flow through the nasal cannula.
Yep.
All right, good. So we are getting closer to this intubation process. Drugs. Now, what are we using?
I think whatever you have available to you that can paralyze the patient as quickly as possible, because you want to just minimize that, in between time. If I was choosing and I had everything available to me and there wasn't a contraindication, I would use ketamine and succinylcholine in this case. I generally like rocuronium, but maybe has a slightly longer onset. And so, which you can kind of overcome by increasing the dose of it. But If there was an additional contraindication for succinylcholine, that's probably what I would use. And I like ketamine as an induction agent.
Yeah. Great. Any different?
Yeah, the intubations that I did recently, I did have to use sucks because it was a person coming in that I didn't have any information on. So I don't know what their potassium is. I don't know what their kidney function is. But as I was doing it, what I was thinking of was, I know this takes longer to paralyze them. They're going to have more apneic time, and I really just want to get this tube in. So I agree with Ryan. If you can use sucks, I almost always use rock just because I prefer it. I think it's safer. But in this situation, if you know their kidney function, you know their potassium, and you can use sucks, I would do it because it's just faster onset.
All right, good. Okay.
One
Let's talk
quick
about,
thought on that.
sorry. Yes.
Then also, do you guys have ketamine over there?
I think that's probably the only drug that's available in many places.
Okay, perfect. Then that's actually good because you're probably more familiar with it. The last patient that I intubated 2 days ago, the nurse just slammed in 200 milligrams of ketamine IV, and the patient went apneic instantly before they were paralyzed, which then made the intubation quite challenging. Because they're not breathing, but they're not paralyzed. So just keep in mind that you need to give that over a slow push and not slamming it in, because the patient will become apneic. And then you have the worst of both worlds, is they are not breathing, but not paralyzed.
Yeah, and this should not be a difficult intubation. So what dosage of ketamine are we using?
I would use 1.5 milligrams per kilogram. Between 1 to 2 milligrams per kilogram IV.
Okay, good.
Slow push.
All right. Slow push, yes. So don't slam it in just because your patient may stop breathing and they're not paralyzed. And that would be a terrible intubation with a lot of risk of aerosolization. Good. So the tube is in. Let's discuss, I think we'll just transition. Yeah, sorry.
One more thing too. So I have not yet seen this, but a lot of reports, Dr. Krager was reporting and a lot of other people were reporting that these airways are very edematous for some strange reason. And this may be like an ACE receptor process. Mel and everyone was talking about this last night, but be prepared for a very edematous airway. So the airways actually are more challenging than they seem like they would be, because this process may not just be pulmonary. What is causing that, I don't think we're sure. From what they've reported, the cords are still visible, but the remainder of the airway, all the soft tissue, is quite edematous.
I haven't run into it yet, but I keep hearing about it, so I'm like terrified to get to that point. But I think if you have a bougie, keep it in your back pocket.
Yeah, have your backup plan ready to go.
People think that maybe this is something to do with the fact that you're going in, the virus is using the ACE receptor to enter the cells, and this is sort of like an angioedema-like picture.
Interesting. All right, just know that we're still at that airway, supraglottic devices. So let's just say for some reason, intubation is not my forte. We have some LMAs around. I know at least we have LMAs. We don't have the laryngeal tubes, but within the country, now we have a lot of LMAs. Can we put an LMA down on these patients?
Yeah.
Definitely. And that's what we're using as our, if the first attempted intubation fails, we're using that as a rescue LMA with a viral filter.
Okay. All right, interesting. All right, so we've tubed the patient successfully. Now we have a vent. Yes. In the most simple way, take us through what kind of vent settings are we looking at, and why specifically do you want to do what setting?
I think if you think about it in
which one? Who wants to do this? Ryan or Britt?
Oh.
No, Britt. Go ahead. Same thing. I'll pipe in if I have something.
All right.
Yeah, and Mel, please too as well. So in the simplest way, this is the simple approach to this is treating it as a ARDS patient. And there's an ARDSnet protocol, which we can actually send out to the group, I think, too. Essentially, it's a lower tidal volume and a higher PEEP. Dr. Kreger taught me a long time ago when I was a resident, thinking about it as that higher PEEP is really important because alveoli in the lungs that are already edematous, they're already going under this whole cytokine reaction and inflammatory state. The worst thing you want to do is when you put air in and take air out, have them continuously collapse open, collapse open, collapse open. It's just really causing more almost like trauma and damage to the alveoli. So if you have a little bit...
I want to take a step back a bit. You've got
farther back
to the end.
Sorry.
We have a vent.
Oh.
We have a vent. All right. So modes, pressure support, volume control. Which one? Which one do you think? Pressure control, volume control, does it matter?
What are you using, Ryan?
Yeah, volume. I would go with volume control because if you are on a pressure setting, then you may be giving them higher volumes than intended. So if you put it on a volume control setting, depending on what your vent is and what that is called there, then you only have 4 variables that you need to control, and that will be your tidal volume, your rate, your PEEP, and your level of oxygen.
All right, good. So 4 things. So we're doing volume now. All right, so you've got 4 things. So tidal volume, how much?
So tidal volumes, and what's helpful too is after this discussion, we can send out the ARDSNet protocol because that's what we're following. And so it's basically the settings that seem to do well for people in ARDS are what we're thinking are the best settings for people with COVID. So volume settings, you want relatively low tidal volumes. So that's between 4 to 8 milliliters per kilogram. In general, you can just kind of split that difference and just start with 6 milliliters per kilogram is a safe dose. Now, keep in mind that kilogram is not the patient's actual weight, but their ideal body weight, because that will be dependent on their height, and their lung volume is not dependent on how much additional adipose tissue they have on their body. In America, this is a big problem for us because we have a very obese population. And so people will come in, at 100, 150, 200 kilograms, and clearly those people, their lungs haven't gotten any bigger, they're just way more. So you need to measure their height, determine their ideal body weight or their typical body weight, and then use that as your calculation for the 6 milliliters per kilogram. And there's online calculators that help you with that.
Yeah, I think you can get it on MD Calc. Yeah, Ryan, go ahead.
For the average 70 kilogram person, that's about like 450 that I'm starting them on usually. But this, like any vent, but especially this vent, this is not a vent that you just set your 4 parameters and say goodbye and check on them later. Like, this is really something that you have to be closely managing and adjusting, because it's not a one size fits all kind of process. And, you start at 450, you might be going down on that tidal volume. I mean, people are going up to PEEPs of over 20. So where you're starting and how you adjust really just depends on how that person's doing, what your plateau pressures are looking like, what your ABG's looking like. There's a lot of factors.
And that's why I'm trying to keep it as basic, because yes, venting an ARDS patient is a bit on the tricky side. So anyway, we'll start basics on 6 mL per kg. And the rate, what rate are you looking at? Are you starting from where the patient was at? So if they're breathing at 25, so at 25, or are you setting slightly less, slightly more? What rates are you putting the patient on?
Without having to try to calculate their minute tidal volumes, I think, coming somewhere close to what they were breathing at is probably appropriate. But if they're breathing 40 times a minute, I might not go that high, because they're probably not going to, on the vent, be able to expire completely, and you'll end up with breath stacking. I think kind of depends on the patient and if they have associated comorbidities like COPD or asthma, but without that consideration, trying to best guess what their baseline minute ventilation was. And I would kind of start in the high teens or low 20s if they're already breathing faster than that prior to intubation.
All right, good. Quickly moving to FiO2s, I'm guessing we're setting at 1. I mean, that's not. And then titrating, do we titrate down? Do we leave it at 1?
I mean, if the patient,
yeah.
Oh, sorry, go ahead.
Go, Bray.
No, you go.
Yes, Bray.
Yeah, I mean, if the patient obviously initially is like in the 60s, I'm just setting them at an FiO2 of 100. But, you know, too much oxygen can be toxic to the lungs as well. So you want to, following your ABGs, following your SATs, you want to decrease that as you go. You don't want to just don't set it at 100 and leave them like that.
So what SATs are we aiming at? Are we comfortable above 94? Or do we need to aim for 99? Where are we?
No, yeah, I think, you know, for patients that are starting in the 60s or 70s, if I can get them even to low 90s with, you know, a good tidal volume and a decent amount of PEEP, then I'm feeling pretty okay about that.
All right, good. Yes, your favorite topic, PEEP. Tell us about PEEP. Yes, so are we setting at 5 or 10 or, yeah, how are we working on this PEEP? Because PEEP is a magic to some extent here.
Yeah, so like I was saying again, like you want to avoid having the alveoli collapsing and reopening, because that's causing even more kind of like micro trauma to them. So that's why the PEEP is helpful. One of the many reasons that PEEP is helpful. You know, I think it's start low and go up slow is an appropriate kind of take on this. You can start them at 5. You can even start them at 10 if they're really hypoxic and you're just not getting their SATs up. But like I said, the patients that I've been seeing in the ICU are on like PEEPs of 20 and even more. So these people need a good amount of PEEP.
All right. So again,
can I weigh in on that, Ben?
Yes, please.
Yeah. So, you know, I think also like just keeping this basic, remember like of these 4 variables that we can control, your tidal volume and your rate are going to help you with ventilation. And typically these patients are doing okay with ventilation. They're not becoming hypercarbic. So, and then what they're having problems with is oxygenation. And the 2 variables that help with that are your FiO2, obviously, and your PEEP. If you look at the ARDSNet protocols, they are associating levels of oxygen with much higher levels of PEEP than you're used to using. So I agree with Britt, for all of these patients, I would start them, if they are hypoxic, and you think and they have a chest x-ray that looks like these chest x-rays and you're suspicious for, you know, coronavirus being the insult that's causing this, I would start with if you're putting them on 100% oxygen, I would start with PEEPs that are, you know, in the mid-teens already. Like 12 is probably a good starting place, and have a low threshold for moving up from there if you're having trouble oxygenating, because you can go up to, you know, 20, 22, 24 if needed, as long as you're checking plateau pressures, and that's more advanced, but just be aware that high levels of PEEP are probably going to be needed and probably be helpful.
All right, so at least a good starting point of 12, and at least aiming upwards and towards the 12 mark, and then as you go higher, you may need to consult. If you don't know exactly how far you're going, then you may need to consult someone who's comfortable with higher PEEPs. Just before we move out a bit from this, IE ratios, I know we said rates of 20s. Does it matter what IE ratio is, we put them on? Is there any fancy IE rationing, or just calculate it based on 1 second in and the rest out?
If this is primarily, if they don't have comorbidities, I don't think you need to mess with IDE ratios. If they have underlying pulmonary problems such as asthma or COPD, then you have to take the same precautions you would take if you ended up intubating them, which is setting a longer IDE ratio. So your expiratory phase might need to be longer because they have an obstructive process underlying that. So, setting that as like 1 to 3 or 1 to 4. But outside of that, I think you don't have to worry as much about this.
All right. Maybe just one, in terms of assuming you got a slick setup, you got time to set up for this, would it be possible, let's say your patient is getting to above 94 to close to 100 on the non-rebreather mask, would it be better than keep the patient on the non-rebreather with nasal pumps on, sedate with ketamine, whoever is asking, sedate, paralyze, tube, and connect them to a preset vent so that pretty much bypasses the whole bugging process?
Yes.
Do you think that would be a more slicker way of doing it?
Absolutely.
Definitely.
Yeah, absolutely. I mean, we're trying to eliminate needing to bag at all. So just that's why, I mean, really it's so important that the RT be in there with you, to have the vent already set up and just connect them immediately.
Okay, good. Wow, all right. All right, and I guess, I mean, so patient is intubated. One thing we didn't talk about is blood tests. So let's assume, so now we've got, because I want to move away from the airway now. I think we figured they have a tube now and they're on a vent, and we've kind of set things up. Blood tests. We are very limited in what tests can order in some areas. In some areas, I've seen people ordering a lot of random tests. Do we need to order blood tests? And which blood tests do we need to order? Which blood tests may aid in the management? Which blood tests may aid in prognostication? Or do we just happily don't order any blood tests? This is assuming, I mean, of course, the other comorbid conditions to think about, but for your typical COVID patient, what blood test should we be ordering?
I mean, again, like there's no perfect blood test that's going to help you diagnose this. I mean, blood tests that we see abnormalities in, normally we're seeing a lower white blood cell count, not what you're used to seeing, a higher white blood cell count with bacterial infections. But again, that probably won't change your management. Lactate dehydrogenase, LDH, has been associated with, if that's elevated, it's associated with a poorer prognosis. But again, if you don't have it, I don't think you necessarily need it. It could point to, it could be part of your prognostic factors. I would definitely get a troponin on these people. A lot of the people that I'm seeing in the ICU are having a lot of cardiac issues. And obviously with just all your sicker patients, you want to monitor for multi-organ failure. So my patient, one of my patients upstairs, their troponin peaked at 20. Sorry, I don't remember what your number is in Kenya, but really high troponins, going into renal failure, going towards needing dialysis. So, I mean, all the labs that you would normally want to check, I mean, I think if they're going into renal failure, you want to know what their potassium is. But as far as like COVID labs, low procalcitonins have also been associated with the diagnosis of coronavirus. I don't think that's going to change your management if you have it or not. But I think basic labs looking at their kidney function and troponin EKGs are crucial.
All right, good. Hey, Ryan, anything on that?
Yeah, no, I agree. I think, we're drawing things like ferritin and LDH and procalcitonin, and, theoretically they give you an idea of their clinical course, but that's just academic. Their clinical course is going to be their clinical course. Those numbers don't really help you. Totally agree. Get a troponin, because I think we're seeing so much cardiomyopathy. I made the mistake. I clicked the wrong button in order to D-dimer on a patient 2 days ago.
Oh, no.
So it's like super high. And so just be aware both that they will, that's an inflammatory marker as well. So they may be elevated without the setting of hypercoagulability, but there is also a thought that COVID is causing hypercoagulability. So if you have a patient and their lungs are looking okay, but they're hypoxic and not responding well, you might, some of these patients I think are prophylactically, because we're not sending everybody to the CT scanner. Some of them are just getting prophylactically heparinized because we don't know. And there is some suggestion that these folks are having higher rates of pulmonary embolus. I don't know. I don't think we know enough now to know that. I wouldn't add a D-dimer. It doesn't help you at all. But just be aware that that might also be a comorbid process that is instigated by the COVID, just to make things more complicated.
All right, good. Because I want to just quickly now move into where people start asking for the word gone, resuscitation. So just to summarize, get an X-ray, CT of no additional value, labs, get physiology labs that you need, liver, just your renal function, and yeah, basic work. So treat the patient, don't go looking for COVID in the lab tests. Just other tests that you will need for the acute management of the patient. Cardiac arrest. So any of you had to do CPR, to do resuscitation on any of these patients?
I haven't had to do CPR yet, but it's coming.
All right, Ryan?
Yeah, I think of the patients that I've seen and that we've been doing CPR on, they come into the hospital and they're just unknown coronavirus status. We are now just assuming anybody coming in an arrest is COVID positive because that's the only safe way to do it. I think the likelihood of if it's a person in the hospital with known or highly suspected COVID and they arrest, I think the likelihood of those patients surviving is very minimal, and you really do have to weigh the risk of exposure to the staff, to compressions, which increases your risk, intubation, which increases your risk. Both LA County and now Salt Lake City County in Utah, the counties that I work in, are adjusting their criteria for how EMS is addressing cardiac arrest in the field and when to transport. But I think if these patients arrest in the hospital or in the emergency department, I've also changed now what I'm doing to limit the amount of people in the room. Instead of having 8 people coming in there and trying to help out with compressions and everything like that, I am recommending basically one person doing compressions while I get the story from EMS, and I'll go in the room and just assess. And if I think the patient has a very low likelihood of survival, I'm stopping. If there's nothing immediately identifiable that I can reverse, I'm stopping resuscitation there, because I think the risks outweigh the benefits to all of your staff, and that's a real risk to everybody.
All right. So I mean, from the literature, and so how many people do we need? Assumingly so I agree with you, there needs to be protocols on who to resuscitate, when to resuscitate, and the ethics around that needs to be discussed at individual facility levels with your bosses and ethical providers and all those people who make big decisions in the hospital. And this, I think, needs to be discussed now, not when the patient starts coming in, because that's when the time start drawing up do not resuscitate protocols. So on who not to resuscitate, I think those are protocols that need to be individualized at your facility level with consultation with the bosses and the ethics people wherever you work. But just looking at it in terms of, if we were to resuscitate, this is where we're assuming we want to resuscitate this patient. And I agree with you, we actually received a patient who collapsed out of the hospital. And I mean, we don't know whether it's COVID, but I mean, from an age bracket perspective, they probably may be qualifying for that. So that's a big risk that's coming in, where people are collapsed and we don't know whether they're COVID or not. So assuming we were to start a resuscitation, I mean, any discussions about how many people should be in this room? Is it one person to do CPR, one person to, are we gonna bag this patient? Are we gonna quickly tube the patient and bag the patient? And then do we potentially look for a third person to give drugs? Here again, probably just adrenaline. What do you guys think?
It's a great question. It's something I've been thinking a lot about, and they just started a COVID resuscitation committee at the University of Utah, which I'm participating in. And so these are my current thoughts on that. I think your first principle that you need to think about in all of this stuff is that, this is in the setting of a global pandemic. And so we can't be treating these patients in isolation. just as they are presenting themselves. We're treating these patients in the setting of what we expect, from a global perspective and from a systems perspective. First and foremost, you have to make sure that you're protecting yourself before. Our instinct as providers is we sometimes accept additional risk to try to save our patients, and we think, we're saving our patients first. But in this setting, make sure, don't rush in to help this patient without appropriate PPE. This is very serious. There are doctors that have, died in China, died in Italy, already dying in the US because they, acquired coronavirus during work conditions. So first and foremost, protect yourself before you go in. And if that means there's a patient sitting there pulseless for a minute or two while you gown up and you get appropriate PPE on, that's just the way it has to go during a pandemic. And then second of all, I would say limiting aerosolizing procedures, and then really focusing on what we actually do that matters in cardiac arrest. And so I would not bag these patients until they are intubated and put on the vent. So if somebody's coming in, you could prepare the vent and they get, intubated at maybe that doesn't happen. I think in Nairobi, they don't get intubated in the field. But if they do come in intubated, having a vent ready and instantly attaching them so you're closing that circuit. Otherwise, I would put a non-rebreather on them, put it on high flow, continue compressions, because compressions are known to help. I would analyze for the need for defibrillation, because that's shown to help. And I think you can do that with maybe even just 2 people in the room, or even just 1 person in the room. The physician in the room can attach the circuit and or can analyze the rhythm. And then, medications, epinephrine, really hasn't been shown to increase neurologically intact survival. And so but it does increase ROSC. And so if we're in a systemic pandemic that we are going to run into ICU limitations and vent limitations, increasing ROSC now has harm to the system if you're not actually increasing neurologic survival. So I would actually, unless this was someone that, maybe give 1 dose of epinephrine, but I would be really limited on giving multiple doses of epinephrine, especially if that meant increase the risk to additional providers or increasing the likelihood that you're going to have a ROSC patient riding a vent in the ICU with low likelihood of neurologic recovery.
All right. That's great. Yes, Brit.
No, I mean, I totally agree. And even our out of hospital arrests, what we are kind of accepting to the hospital, what we would do a month ago and what we're doing now, like Ryan is saying, our protocols are changing. So if it's somebody in the field where they're not getting ROSC, or maybe they get ROSC for a minute and then they go out of it, it's actually somebody that we're starting to assess, like, do we really bring this person into the hospital? Do we expose everyone? How long are we going to run this code? What are their comorbidities? What's their likely outcome? I mean, all of that has to, in this state of pandemic, really needs to be assessed, because I mean, as Ryan said, the longer you run this code, the more people you need in there doing chest compressions, the more you're aerosolizing with bagging. I mean, you're just putting people at a ton of risk, and there's limited resources. We're going to start running out of vents. That is just the reality of it. It's already happening in New York. So it's something that, it's a decision you kind of thought you would never be making as a physician in California, but starting to think, like, who gets that vent and who does it, and who has a shot at a really good outcome and who probably doesn't, has a huge part of this decision of running the code and how aggressively you run it.
All right, good. All right, I think I have one more question, just to answer from the questions. And then after that, we'll probably open it up for people to actually voice their questions. Then I'll unmute everyone. Pediatrics. Any experience? What's happening? Are there kids? Are there no kids? What's going on?
Yeah, so there's actually been a really big study out of China recently that had like over 2,000 kids. And what all studies at this point are limited, just pregnancy, children, everything. But what we seem to be finding with kids is, yes, they can get the virus. For the most part of these 2,000 kids in this study, I think like 90% of them either were asymptomatic or had mild to moderate symptoms. I'm not sure yet if there's been any confirmed COVID pediatric death. There's been a couple deaths in China, but I don't think we're actually completely 100% sure whether that was from coronavirus or something else that was going on. So, you know, if I had to take a guess, there's probably been a couple deaths in children, but for the most part, if they get the virus, they're having a very mild course with the virus. I think one of the really important things to think about with pediatrics, though, is who they can be exposing the virus to. So this is not a time, I mean, kids need to be keeping distance from their elderly grandparents, because even if they're not showing symptoms or they just have a runny nose or a little mild cough, they could be spreading the virus and really affecting people that are going to have a much more severe disease.
All right. Any of you seen admitted patients because of COVID? Pediatrics, that is. Any in your setting?
Pediatrics? No.
All right, that's good to know. All right.
Hopefully it stays that way.
Yes.
Ben,
yes.
there was an earlier question, which is a really good question about proning these patients that I wanted to address.
Yeah.
So
Yes. Sorry, I forgot that. Yes.
Yeah. So that is definitely part of the protocols once people are intubated. If you have a way to prone them when they're intubated, it's challenging, obviously. And so it kind of requires a lot of resources to do without breaking the circuit and without putting the patient at risk if they're unconscious. But we're also so yes, if you have the ability to do that when intubated, but we're also seeing a lot of benefit in non-intubated patients by proning them. So getting them, you know, if they're on high flow nasal cannula or on CPAP, still proning them while they're conscious is possible. You can use from the OR, sometimes they'll have that like kind of frame for, you know, surgeries that are done prone, just like a head pillow from the OR you can use. So allowing your patients to roll over and maximize, you know, lung expansion in all areas of the lung, I think is important. So it's a great question and should be utilized early.
Right.
Yeah,
Yeah.
my friend who's an ER doctor in New York, who's just getting destroyed by this, said that was his one major recommendation for me, was that prone these patients and prone them early. If they can tolerate being on their stomach, just flip them. He says he's seen, by just proning the patients, he's seen improvements in O2 sats from 5 to 15% by just proning them. So in his experience, it's been extremely helpful.
All right. So I guess even in the AD, as you're thinking of, are we close to intubation? How sick is this patient? Then just asking the patient to lie on their tummies while they're getting their oxygen probably is a good
If
thing
they
to
can
start.
tolerate it, do it.
Okay, good.
Yeah, if
So
they can
that's
tolerate it. If they're already failing, then that might be very uncomfortable and harder to monitor. But yeah, if they can tolerate it, for sure.
Something about the mask wearing question?
Yeah, the mask wearing. Okay, let me do this. So I'm gonna allow you people to unmute yourselves. So please do not unmute yourself all at once. Maybe we'll start with Tony. Tony Muyunga Mukasa. Let me find him here. Let me just unmute you, Tony. Tony, what's your question? Hi, Tony. Can you talk?
Or is it Tom? Is it Tom, Ben?
Sorry, Tom. Yes, sorry, Tom. All right. So about mask wearing question, I'm not sure. Maybe can you clarify your question on the text, please? What exactly? Yes. In terms of Nokia 2.2, PPEs are the same for everyone. There's no PPEs for different colors. PPEs are the same. Anyone else with a question, just look at the mic, which has a red cross on it, click on it, and you'll be able to ask your question. We've got 15 minutes left. We can potentially fill some questions.
And also, Mel, if we missed anything or you have anything to add, let us know, please.
Yeah, actually, I've got to jump off and go to another call, but it's been a really interesting discussion. But I think the much more important discussion is to be thinking about when you become overwhelmed. I think it is inevitable, unless there's something that Africans have that the rest of us don't have. You're going to be hit by a pandemic, and it's going to be probably as bad as 1918. And that means you're going to quickly be thinking about proning and venting patients, but then you've really got to think about palliative care and who is going to get what. I really think the discussions going forward should be about how's your hospital going to deal with that, putting up tents, and really thinking about this when you've got a system that's going to be completely overwhelmed. I've been talking to a lot of people in very low resource settings in the north of Canada and other parts of Africa. And really, it's about palliative care when this thing really gets rolling. And they're very difficult discussions, and you don't really want to have them because it's a little depressing. But if you don't have a plan, it'll be chaotic. I think you really do need to start thinking about it in terms of, okay, the first wave we'll be able to deal with, but this has an exponential progression. And how are you going to deal with that? And I think it's basically tents and it's palliative care. And as much as possible, people going home, even the patients that are very sick to die. Very, very difficult discussions. I mean, here, even in the US, which is probably one of the best resource places in the world, New York is completely overwhelmed in some hospitals. It's not about running a cardiac arrest in an 85-year-old. It's just not happening. It's just about saving as many of the youngest patients as you can. And for everybody else, it's palliative care. So it's a depressing thing to leave you on, but I think that's where the discussion should be going forward. Unless, again, you're very lucky, and it could be that you don't see what everybody else has seen, but it's so far, everybody who thought they were lucky is just simply 4 weeks behind the rest of the curve. Here in LA, we're about a week to 2 weeks behind, we think. New York, we've done a lot of good social distancing, so it might not get as bad there. But the only thing you can hope for is, from a public health point of view, is doing all those things to slow the curve. Everybody will end up still getting it, but if you do the social distancing and the hand washing, you might be able to spread this out over a longer period of time. But if you don't, you'll have a huge peak, and it'll occur over about a 2 week to 4 week period where you'll simply have millions of patients that are sick.
Thank you very much, Mel. I'm seeing some questions. Just if this video of this whole discussion will be available, we'll share off a link. So there's some questions that are being asked that were answered earlier. So watch the video, you'll get your answers on PPs and stuff. The whole idea of today's talk was to talk specifically about AD management. So the questions on comorbidities, community spread, I think the best resource would be a WHO websites. I'm not sure, because most of what the idea for this one was specifically to focus on the clinical aspects on AD management.
There's a question about that mortality once they get intubated, super high, like up to 50%.
All right, and also there are no scoring systems to decide who to intubate, who not to intubate, right?
There have been proposed scoring systems as far as like mortality and morbidity, but not for intubation.
Okay, all right.
And these scoring systems, again, it's all about the clinical picture. It's all about how the patient's doing. And for intubation, really, if you can just give them oxygen and prolong intubation as much as possible. But once that patient gets too tired, you don't want to get yourself into a really bad situation where you can't get them pre-oxygenated at all. Now you're paralyzing them, and now they're coding when you intubate them.
All right, I see Boniface. Do you have a question? Sorry.
Yeah, so.
Yeah, you have a question?
I do. Yeah,
Yes.
I do. Yeah, I just wanted to find out, in terms of very good talk and all that, I just wanted to find out is for healthcare workers, in terms of like, once you get exposed, do you really need to be quarantined if you actually get exposed to a patient who's tested positive for COVID, or are you supposed to get tested for the COVID itself?
So
So
the way
Good
that it's been
question.
working for us,
Yeah.
the way that it's been working for us, and I keep getting emails from the county like, you've been exposed, and I know I've been exposed. I'm exposed every day. Again, this is just, we get emailed when we've had a positive test that came back. But like I was saying, we're testing about 5% of the people that I actually think have coronavirus just because our testing's so limited. I think it just depends on your hospital's protocol. If you get exposed, absolutely not. You don't need to be quarantined. You're a healthcare worker. You're going to be exposed every day from this. If you become symptomatic, absolutely, you should get tested, because if you're starting to develop any symptoms, coming to work and spreading that virus is the last thing you want to do. Now our county system is their protocol has been check your temperature once and record it and call us if you have symptoms. And so, our whole healthcare system has been so overwhelmed by this that our protocols keep changing. There was, if you were exposed, then you were quarantined. And now if you're exposed, you check your temperature. And if you develop symptoms, then you get tested. I would go by your hospital's protocol, because it's going to be different everywhere. But you're going to be exposed all day to this. And so that's why wearing the PPE is just so important, because that's the best way for you to protect yourself. And if you wear it all the time and you wear it appropriately, your risk of actually contracting the virus is very low. But as long as you have goggles, mask, glove on, you should keep yourself protected from your daily exposures.
Actually, that's a very good point, because some of us have tried some of these protocols. Because if you're exposed, you saw a patient, they didn't qualify, they didn't mention about anything about COVID, but some of them got tested, so none of us had a PPE at that point. Should we quarantine staff for 2 weeks? What's the sense from your setting? Should we quarantine this staff for 2 weeks, or should we just tell them to come and test if they start developing symptoms? What are you seeing in your setting? Because this is some of the decisions that we need to, especially where we can't keep sending everyone for 2-week holidays. It's our holidays, a quarantine, but we cannot actually afford to keep sending people out every time they get exposed. And you mentioned correctly, everyone is kind of showing up. So what are you seeing in your setting? What are they doing in your setting?
And Ben, you're saying that
Britt, let me pop in here real quick. Because the CDC has actually published guidelines on this, and so I've included the link here in the chat. So they basically they've kind of come up with a way to determine high risk, medium risk, low risk, and then recommendations for that. Now, keep in mind, the CDC has not been completely on point during this whole thing, so you have to take this with a grain of salt. But that is kind of some accepted general guidelines that are put out by a major entity that are worth taking a look at.
All right. I also think WHO had something, so also check on that. Ryan, sorry, Bridge, go ahead.
So that's what I was just going to say. As long as you have, so at this point, this is why I'm saying you should always wear a mask and goggles and gloves at work all day, the whole shift. Because as long as you're wearing that, if you look at that CDC guideline, you're automatically considered a low risk exposure, which doesn't need to be quarantined for 2 weeks. And you want to protect yourself from patients. You want to protect patients from yourself in case you're carrying the virus and just haven't developed symptoms yet. But as long as you're in mask and goggles and gloves, you are considered a low risk exposure.
Yeah, I think the challenge is none of us have enough resources to be dressed that way, which is a challenge. But yeah, so I think we'll probably have a look at that and share out some information on that. I think that's going to be a big issue in terms of quarantining people who've been exposed. When should they go to work? When should they be tested?
And the goggles, I have had one pair of goggles for weeks now, and I just wipe them down with a sanitizing wipe, and then I wash them with soap and water after every shift. And until the plastic breaks down, they're the same ones I'm going to use probably for another month.
So that's a good idea. I mean, get your own and just keep washing them. That's probably a good idea.
Also, just
yes.
in these risk assessments, they include whether or not the patient was wearing a mask. So, so if you have the resources available to it, at the very least, the high risk, we assume everybody has it, but at the very least, people coming in with fever, cough, shortness of breath, if you have the ability to put a mask on them, that decreases the risk of exposure to healthcare workers.
Okay, so we got 7 more minutes to this. Prone resuscitation, that was actually a question that, yes, any evidence? Does it make a difference? Should we even bother? Prone resuscitation, prone CPR.
Prone CPR? I would not, no.
No, don't go to that level.
But yeah,
Right.
but proning, yeah, we discussed that. I would recommend it if you can.
Okay, so proning
That
when they're
won't help your
live.
chest compressions.
All right, so proning when they're live, if they're going to cardiac arrest, prone resuscitation is not really being recommended at the moment. All right, in terms of questions on isolation, kindly check. I think there are a lot of guidelines from WHO. I'd want to spend the next 6 minutes discussing any clinical concerns, any clinical questions. Feel free to just unmute your mic and ask the question. Yes. Nicholas Nyamai, let me unmute you. I see your hand is up. Nicholas, go ahead.
So my question is about discharge, the patients you get to discharge in the ED. So I've seen, I'm not really clear about the CDC recommendations. So there was CDC recommendations with treatment with chloroquine plus azithromycin. And then there's some French doctors who are recommending vitamin C discharge from the ED. I don't know what your experience is in terms of the patients we see, we think we can discharge home, who come back maybe a positive, COVID positive, but need to be isolated from home. Do you discharge them on meds? And are these meds going to reduce the symptoms? Like, I don't know what your recommendation is.
At this point in the US, those medications aren't actually approved. Some hospitals, I've seen some infectious disease doctors at different hospitals using them based on what evidence we have, but we're definitely not discharging those patients on any medications other than quarantine, stay hydrated, take Tylenol for your fever. But there's strict quarantine discharge instructions, but there's no medications that we're prescribing outpatient.
What about those inpatient? I see someone asking about chloroquines. What about them?
Yeah, like I said, there's been a lot of studies out of China, and it, in some people it might help. There's just not enough evidence to say that they're not necessarily dangerous as well. We know that they have some cardiotoxicity effects. They prolong QT, that increases your risk of torsades. And so inpatient with infectious disease, sometimes they're deciding to use it on the right person, but it's not something that the US has widely accepted as a regular treatment. And we've actually been seeing cases where people are just deciding to take it outpatient and dying because they go into torsades because they're already taking other medications that prolong the QT. Then they add the hydroxychloroquine and have cardiac arrest. So we're not discharging them with them. We're not widely using them in the hospital. It's really at this point more supportive care than anything.
All right. Carrie, I see. Oh, sorry, Ryan, you had a comment?
Just to add, just in patients with severe disease, like if they're getting intubated or close to it, right now, LA County and Utah are recommending the hydroxychloroquine, but I think we have a really lack of evidence, and it may be that it's causing more harm than good, but I think it's because we want to do something and we have nothing else. And so we've been giving it to patients with severe disease, but I think there's a lot of studies ongoing that will tell us if we're actually harming patients by doing that. But certainly not as an outpatient.
All right, Mikaria, yours probably will be the last question.
Actually, maybe to finish up with a positive question. For those who have recovered, is there a risk of
yes, please.
spreading the disease, or we should be happy that they're recovered and they're safe to move to the community?
Sorry, are you talking about recovery and then if they're still spreading it?
Exactly.
Like they're a
Yes.
carrier?
Yes.
We don't know actually how long there is the viral shedding. That we're not 100% sure of. What the recommendations, the CDC recommendations change frequently, but the last CDC recommendation said if you have symptoms, 7 days after symptom onset, if your symptoms have greatly improved and you've been afebrile for 72 hours, you can return back to work.
Okay.
All right. All right.
I'm not sure how evidence-based that is, but that's what the CDC has been recommending.
All right. So I'll just take this last 2 minutes to thank Ryan and Bray for taking their time. I think there's a lot of things we've learned from this, and we'll try and do some more discussions online. For everyone, this video will be available so you can replay it in your departments, replay it for your staff, share it with your colleagues, so that people can learn a lot and we can spread the knowledge. Because as I said, it's if and when it's coming, so there are many discussions whether if it will come and when it will come. I think us at the front line being 100% prepared is the most important part. And for us, that's the main objective, to make sure the healthcare workers really have a feeling of what's coming and real first-hand experience. So Bray and Ryan, a lot of thank you for sharing your time. And I see people are worried about how you guys are managing your stress, but based on the fact that I saw Ryan drinking something, I'm not even gonna ask what that was.
It's 10 in the morning. It's 10 in the morning, Ben.
And,
Coffee, Ben, coffee.
so see you guys are busy, smiling and happy. So I guess we'll be able to manage. And we will hold more sessions. We probably will have Bray and Ryan come back again and discuss different aspects of it. But I think this was a great session in terms of capturing a good chunk of ED COVID experience. And Ryan recommends MRAP. There's an MRAP COVID page that has additional links, useful information available. Yeah, we will put potentially a link on that also on our page because we work a lot with MRAP, and we also have a COVID page, and all of this will be available there. So thank you, everyone. I'm just gonna end up this meeting. It's at 9 p.m. in Nairobi. We are off to sleep. So thank you all, and thank you for joining. Till the next one, we'll let you know when the next one will be available. Thank you guys, and goodbye, and good day, good night.
Good night, y'all.
Bye.
Stay safe.
All right.
Thanks, Ben.
Cheers.
Thanks, Ben.
You're welcome. And meeting.